want to extend a special thank you to Rabbi Glatt, who made himself available on relatively very short notice to speak here this morning. We're very, very deeply appreciative of that dedication as well. Our last speaker for this morning is Dr. Martin Grossman.
Good morning. First, I'd like to say that I'm honored to be speaking in front of Rabbi Schechter and Rabbi Dr. Glatt. I hope that my presentation will be as equally beneficial and elucidating as theirs were. So my job is to talk to you about, in some ways I think I have the easier job than the rabbis do, because, I'm just going to follow what the rabbis say regarding the specifics of the details of what's going on. It's my job just to present the information as I see it as a physician. Rabbi Glatt mentioned Elu ve'elu divrei Elokim Hayim. That is correct when it's regarding to two psak. That is not necessarily correct regarding two physicians, because physicians are not giving psak halacha. So the question is, what is the reality of the situation? And I'm going to give you a story that happened quite recently, actually, just to give you illustration. When we look at the avot, and they gathered their children around right before they were about to die, there was something involved in what the fathers were giving to their children. They usually give them a tzava'ah, they usually give them an instruction, and the instruction wasn't left on a piece of paper for them to read after their nifter. The instruction was specifically given to them word for word. Then, of course, there's another concept also of, we know in the brought in the Shulchan Aruch regarding vidui, the confession that a person does before they pass. There's some shilas about that. Speak to your Rav about that if it's needed in that situation. So I had a patient, and basically he was very, very sick. And the kind of patients I'm seeing are really the most ultimate chayei sha'ah. Chayei sha'ah, like the rabbi said, is a prognosis of less than a year. Most of the patients I'm seeing often have a prognosis of weeks, days, sometime. And this patient was in that type of matzav, in that situation, and he had a family, a big family, and basically, the family didn't want me to let him know really what's going on, and of course, he was able to make his own decisions, so I felt that out to see if that was the case. And when I spoke to the family about it, I said, if anybody can hear what's going on, I think he can. This is a person who was well-learned. He was teaching Torah for his whole life. But the family said that they would prefer him not know if possible. So I saw the patient, and I was speaking with him. I spent about an hour with the patient, sharing Divrei Torah, of course, trying to do whatever I can to improve his matzav, not just with medication, but with a little bit of Torah. And then afterwards, the family called me to come back into the room because he wanted to ask me another question. And then he started asking me questions about, well, what's the next step? What do we do next? And he started mentioning, various treatments, chemotherapy, and other things. And really, he was beyond the point where chemotherapy could help him. I sort of said, well, right now, you're here to we can get you stronger, to get your pain under control, to get you improved, and then we'll see how things are going. And then he asked again about, what about the chemotherapy? And I got a sense that he really, really wasn't satisfied with what I was saying. So finally, I sort of said to him, he was sick. It was over the Yontav of Yom Kippur, and there's a custom or a good practice that people do. They ask mechila from their parents before Yom Kippur. And basically, the children did not have an opportunity to ask mechila from the patient before Yom Kippur because the patient was so sick that it was not shayach. Just so happens that at this particular time, it was shayach for him to be asked that question. And the children had asked me the night before, and I basically gave a little roundabout way. I said, well, you can tell your father that, Yom Kippur came and went. We couldn't ask you for mechila, but now it seems to be you're doing a little bit better. You're certainly able to appreciate it. Maybe, you can ask him mechila then. So I told the patient that don't be surprised today if your children come in and start asking you for mechila, and they are going to come in here, I promise you that. And it's because I told them that they have to, because you were not able to be asked that question before Yom Kippur. And then once again, he started to ask about what else. And then I got a sense that he really knew what was going on. He wanted me to tell him. So I did. And the one thing I told him, I said, it would be very, very good for the patient to perhaps, have your son help you to say the vidui. He looks at me, points his finger like this and says, "This is what I was waiting to hear." Maaseh shehaya. So when we see that Yaakov Avinu prayed for Choli, and we know Rashi says so he can give a tzava to his children, and the Gemara says that the reason it was done over there is because give the children time to come see their parents. But there's another reason why we may have a little bit of advanced knowledge of when we're passing, because there may be certain things about our own house that we'd like to get in order. And I think often, it has to be done very, very carefully, and to know we don't want to make any patient worse based on giving that information over, so it has to be done sensitively. But there's something to be said about when a person is coming to the end of life. The rabbis talk about, the poskim talk about a death called nishika. We all understand that one day all of us are going to come to that level, and I hate to be bringing it up on a Sunday morning, but that's what you're here for. You came for end-of-life talk, so we need to talk about it a little bit. And if I asked anybody in the room who would not want to die with mitat nishika, a death with a kiss, nobody would raise their hand and say they don't want to die like that. Everybody, if it comes time, and really there's not much more that can be done for curative therapy, everybody would want to have mitat nishika. And of course, the straightforward answer is that some people, when they pass from the world, it's like a hair going through milk. But some people, when they pass from the world, it's like taking thorns and bringing it through cotton, which means how is the neshama leaving? And that's more of a reflection of how a person lived their lives when they were in the olam hazeh. Was their focus on how big my house is, how many cars I have, how many vacations I take, how much my bank account is, how much money I make? Or was my focus on the mitzvot and maasim tovim in the Torah that I'm learning? Because if a person has properly prepared, a person who prepares during the week has something to eat on Shabbos. A person who doesn't prepare during the week has nothing to eat on Shabbos. So hopefully everyone here is preparing as best as we can, doing our avodah, so that when it comes time for that, we can potentially have that mitat neshika, because we know that we've done what we can, and nobody's perfect, but we've done what we can to prepare for that ultimate end. What I'm here to also talk about is there's another aspect to that, and that is to make sure that the symptoms that are related to patients when they are dying are managed properly. And I have to speak on behalf of physicians, present company excluded, of course, Rabbi Dr. Glatt. Most physicians do not have the expertise to manage the symptoms that are associated with end of life. That's not what they're trained. That's not what they're taught. I wasn't taught that when I was in medical school. I wasn't taught that when I did my residency program. This is something I learned over the span of the past 20 years since I finished my residency, and have gotten involved in a specialty called hospice and palliative medicine. And for a person to be able to talk to his children or talk to her children, for a person to be able to accept what is going on with YIQV, with proper understanding, the symptoms of the illness must be managed. And therefore, just like a person is obligated to get a rabbi or to go to their rabbi, and then their rabbi is obligated to ask a question of a baki in these areas, an expert, in order to get the proper psak halacha, a person is also obligated, according to how I look at things, to find a physician who is going to be able to manage those symptoms that are associated with the end of life. And specifically, let's just talk about pain for a moment. Rabbi Glatt had mentioned regarding pain and the dangers of morphine, that it can hasten death. All medications have side effects. Some medications that are very well known can cause death. Tylenol, if taken in a dose of more than 7.5 grams, can cause death in 50% of people. Tylenol is a medicine you give babies. Tylenol is a medicine you give pregnant women. Tylenol is a medicine that we don't even think is a medicine sometimes. So all medications have inherent dangers. When a person is going for chemotherapy, these medicines are poisons that are being used for a specific reason in order for a benefit, and studies have shown that they've helped in these patients. Okay? But make no mistake about it, the wrong dose of chemotherapy can often kill a person. So there's no difference between that and other medications that we commonly use to manage symptoms. The key is, just like you may have a wonderful, wonderful primary care doctor, And if, God forbid, a person had an illness that required chemotherapy, there are no primary physicians that will prescribe chemotherapy unless they happen to also be oncology trained. So which means a doctor has to have familiarity with the medications, the side effects, and the doses that need to be used, and how to escalate those doses in a way that manages the patient's symptoms and doesn't hasten the patient's death. Now, inherent in medicine, there's always a potential that sometimes things can happen. There are patients who get the regular dose of chemotherapy and have an adverse reaction and die from that. That is inherently in the practice of medicine, which is why specifically the Torah has to give permission for doctors to heal. It says over there, Mikan, from here we learn that the Torah gives, Hashem gives permission to doctors to treat. Because with the understanding that we know as best as we can, but sometimes there are inherent risks in what we do. The opiate medications, which I'm talking about, is morphine. That's the one that everybody knows about. That's the one that chuvas, but there's Dilaudid, there's fentanyl, there's other medications. These are indispensable medications when they are needed. In fact, in my experience, and I'm doing hospice for about 8 years, for 3 years exclusively, and previously to that part-time. I can tell you based on my experience, and there are studies that seem to suggest it, that patients whose symptoms are managed properly, they live longer. And not just live longer suffering, live longer without suffering. Nobody has to die uncomfortably. There are wonderful medications. There are wonderful ways to give those medications that nobody has to die suffering. And most of the time when I'm meeting families and they're so concerned that their loved one is suffering, what's really happening in psychiatric parlance is transference. They are suffering emotionally by what's going on, so they are looking at the patient and thinking the patient is suffering. And I will turn around to say to them, you are suffering more than the patient is right now. But in order to get that level, there has to be certain understanding that, okay, maybe the physician team, there needs to be someone else on the team that can help to manage symptoms. And I'm not even necessarily talking about end of life. I had a young man when I first was in the specialty of palliative medicine, a 27-year-old who had metastatic colon cancer. And when I saw him, for all intents and purposes, he was dying in the hospital. He was absolutely miserable. Pain was uncontrolled. And within a very short period of time, with Hashem's help and what I'd learned in medicine, I was able to make this patient comfortable. We were able to discharge from the hospital in 2 weeks. And then 6 weeks after that, he reported to the oncologist to get treatment and actually called me to ask if he's allowed to drive with the medicines I was giving him. And I told him that wasn't a good idea. And he lived for another 2 years afterwards and then succumbed to his illness. So managing the symptoms of illness is not only if a patient has Chayei Sha'ah or has weeks to live. Managing the symptoms of illness is important even if a person has a prolonged or has potentially more time. Because by managing the symptoms associated with these medications, especially the chemotherapy medicines, patients can actually take their chemo. It is currently the recommendation, if not soon to be the standard of care. Any patient that is diagnosed with metastatic cancer of any type must have a palliative care evaluation as well. This is a quality indicator of the American Cancer Society and the American College of Surgeons. So we see that there's a concept of providing this level of treatment even when patients are able and have more time. So specifically regarding the opiate medications, they're very helpful, and there's no reason, if they're being managed properly, that they should shorten life. There's another reason why we give opiate medications, and that's for a symptom called shortness of breath. And shortness of breath is sometimes even worse than pain, because pain, while sometimes it's constant, sometimes it's episodic, comes and goes. Shortness of breath, especially when it's associated with end of life, is often constant and unrelenting. The opiate medications are also wonderful for managing those symptoms. And remember, we're talking about patients, if they have congestive heart failure, they've already seen the experts in the world and tried to give them the right doses of Lasix and other medications to help the symptoms of the illness, and yet they are still uncomfortable. Or if they have COPD, they've already seen the pulmonary doctor. The pulmonary doctor has done whatever they could to manage those symptoms. The symptoms are still present. And as people get closer and closer to the end, the symptoms often escalate. So that's where we can use these medications to manage these patients. And just to quote you a study, just to show you a little bit of what I'm talking about, there was a study done where they took patients who were on ventilators, who the family made a determination that they wanted the patient off the ventilator. Of course, as the rabbis have said, this is something that is withdrawal. This is not permitted in that circumstance, but I'm not going to be posek. Each case is different. You have to ask your Rav. But these were not from people. These were, just a study done. And they wanted to see which patients lived the longest off the ventilator. Now, mind you, if the patient was on a ventilator and the doctors felt the patient could come off the machine, the patient would be taken off the machine. We don't keep people on ventilators for no good reason, hopefully. These were patients who were determined could not survive off the machine. They failed their weaning trials. And lo and behold, they stratified into 2 different groups. One were cardiac and pulmonary, which is heart and lung, and the other one were brain. And they found that the patients who lived the longest, measured in obviously minutes, but it really was days when you extrapolate it out, were the ones who on an average dose of morphine about 7.5 milligrams an hour. And the ones, and I'm not recommending these doses just to you should do these things, but everything has to be done properly according to expertise. And the average dose that was with the longest survival for patients with neurological illnesses was 2.5 milligrams an hour. So, and these are doses that we will sometimes use. Not, we don't necessarily need to do those doses on a regular basis, but just to show you that when these medications are given, the patients actually live longer. There's no question about it. If they're given too much, they will shorten life. But that comes back to what I said about making sure that you have an expert, the baki in these areas, to know how to manage these medications. And not having an expert, it can cause problems in 2 ways. It can cause problems of overtreatment, but given our current climate of how most physicians practice in, that's not what happens. Most of the time, it results in undertreatment. And I can't tell you how many patients I have coming from some of the most wonderful institutions in Manhattan, and in Brooklyn, and in Queens, and in Long Island, that their symptoms are still not managed despite the fact that they've been in the hospital for 2 or 3 or 4 weeks. And they come to our setting in Menorah or in Silvercrest, and we're able to get those symptoms under control. And sometimes it's just a matter of adjusting the way the medications are given and not necessarily the doses of the medications that are given. So that's really about pain and shortness of breath. I want to talk a little bit about withholding medication. As patients get closer and closer to the end of life, certain medications that they were accustomed to taking their whole life, which may have gotten to them to the point where they are now, where they can actually be living long enough to have gotten to some of the other illnesses that happen as people get older. Blood pressure medications, diabetes medications, all of these involve a physician's expertise in when to prescribe and when not to prescribe. And I'm not talking about stopping the medicine because we want the patient to die sooner. That is not what I'm talking about. That is not allowed. What I'm talking about is understanding what medication is being used and what is being used for. Blood pressure medications are generally what we call long-term investment, right? Short-term, it's not for the short term. So if a patient's blood pressure is 150 or 160, often we hold the blood pressure medications because some of the side effects of the opiate medications are to lower blood pressure, and we want to be able to give those medications. So patients who often on medicines they've taken their whole life, a physician will say, well, we don't need that medication anymore. Now, there's 2 reasons the doctor is doing that. One reason is for the first reason, withdrawal to hasten death. That is not what we're looking for. But another reason is, well, then you ask, why do you want to stop the medicine? Well, it's not needed. Why is it not needed? The educated consumers, why is it not needed? And see the answer. If the answer is, because I'm not so concerned about the blood pressure right now, because I think the patient's prognosis is less than a week or 2, and really the blood pressure medications are no longer helpful. That's a different answer. That's a different question. If that has to go to the Rav, then so be it. It goes to the Rav, but that's the answer you're looking for. The diabetes medications, personally, I would rather have a sugar of 250 or 300 than have a sugar of 50. And often in patients, when they come into the end of life, their eating is erratic. First of all, most of them have already lost a lot of weight, so some of their diabetes has already been treated by weight loss. But even for those who didn't have a weight loss issue, sometimes giving these medications, you give the insulin, then suddenly they don't eat for breakfast, they don't eat for lunch, and now you're dealing with a hypoglycemic episode that can rapidly cause death much faster than hyperglycemia can. So a physician has to know when to prescribe these medications and when they are not indicated under the certain circumstances. And that's regarding most medications, and that's vitamins and things like that. You know, when a patient is only going to swallow 2 or 3 pills in a day, you want to make sure you're going to get the biggest bang for your buck on what they're going to swallow and not waste time with things that perhaps there is no medical data to suggest they're of any benefit. And these are the kind of things we very commonly deal with in hospice, especially when patients come on to program, what medicines we're going to continue. Cholesterol medications, really not necessary if a patient has a prognosis of 3 to 6 months. I have my cardiology friend listening over there. Maybe he agrees with me. So these are medicines that we don't need to be giving to these patients, not because we're trying to hasten their death, but because we're trying to improve their quality of life and be realistic about what's important in the setting of coming to the end of life. Rabbi Glatt mentioned about artificial nutrition. I can't stress what he said more. This is such a common issue. When patients are coming to the end of life, generally they eat less and less as time goes on, and then comes a point in time when they stop eating. The most important thing you need to have an idea is what is the prognosis of the patient, and that's another reason why you have to have physicians who have expertise in prognosticating. When they did a study comparing regular internists to palliative care physicians in prognosticating, which means telling how long the patient is going to live, most internists overestimated by 2.5 times the patient how much they're going to live, and palliative care we overestimated by 40%, because most doctors are inherent optimists. We go in because we want to try to help people. But the 40% is closer to accuracy than the 2.5 times more. And to understand what the patient's prognosis is also very important for the rabbis to paskin their shilas, as we heard today. And that's why it's so important that when you have a posek, the posek should speak to the doctor, or the doctor should speak to the posek. Because families are emotionally compromised. They are going to filter the information, not willingly, but they're going to give the information in a way that often, like Rabbi Glatt said, sometimes, no, that can't be what's going on. That just doesn't make sense medically. And if a rabbi is not a physician, they're not going to know if that information is correct or not, unless they happen to have a lot of experience, like Rabbi Schechter, with dealing with these types of questions in a medical standpoint. So it's so important sometimes, and I will insist if I'm the physician and I have a difficult family, sometimes my colleagues will say, oh, it's so difficult to take care of Orthodox patients. I'm like, oh, no, it's not. It is so easy. All I need to do is say, who is your posek? And first of all, if the person is paskin shalas from themselves, that closes that door. You're paskin shalas for yourself? Really? Oh, I'm not sure that's allowed. We can ask the rabbis here if you're allowed to paskin shalas for yourself. And then once you find out who the posek is, I say, may I have his number? And then I call the Rav, and I'll tell him the medical details of what's going on. And then the Rav makes a decision based on at least what I have perceived to be the reality of the situation. And perhaps maybe sometimes the rabbi should speak to more than one doctor to get what we call a consensus opinion, because in medicine, level 3 data is consensus opinion, and that's what we base our practice often on, consensus opinion. So that's about medication withholding and artificial nutrition. Now I want to talk about hydration, and Rabbi Glatt also mentioned that, and that is such a significant issue. The art in what I do is to know when to hold the fluids. Patients will come to me from hospitals. They've been getting fluids for weeks on end, and they're within a couple of days of life, and they start having increasing shortness of breath and gurgling. It's uncomfortable for them. It's uncomfortable for families. We have medications that we use to dry up those secretions and make them better. But the key is to know when to hold the fluids. And when we say hold the fluids, I don't say discontinue the fluids. I will almost never say to discontinue the fluids. If I see a patient who I think is a very limited amount of time, and there's evidence that the fluids is contributing to the patient's suffering, I will speak to the family and then to the Rav to say, I think we need to hold the fluids for 24 hours and reassess and see what's going on. If the next 24 hours, just like the rabbi said, the shaila could be, the psak is completely different in 24 hours. And that's the kind of connection you have to have. And as far as the Rabbanim are concerned, I remember we had a patient over in Menorah, and there was one patient there, and he was one of the congregants in a rabbi who's in Brooklyn. And I remember I would call the Rav regularly to ask him all kinds of questions, and he would say, I can't answer. You need an answer right now because I want to come in and see the patient myself. He would come in every time I had a question. He would come in, see the patient, and make a determination based on what he saw, looking at the mitziyut of the situation that he saw in that situation. I'm not sure that's practical all the time for the poskim to do, but that's what Rabbi Glatt was mentioning about having your community rabbi involved, because the community rabbi hopefully should be close enough to his community members or one of the rabbis in the community to be able to give that level of attention. And certainly as a physician, I have to say also that many times families will come to me and say, I spoke to a doctor and he says we can try this. This just happened last week, actually. They were thinking about giving a patient, another dose of chemotherapy, despite the fact that the expert they had seen, who was recommended to them from the Rabbanim in Eretz Yisrael in New York, had told them and called me personally to tell me there was not much more that could be done as far as curative treatment. But they still wanted to know, is it okay if we call somebody else? I'm like, you can call anybody you want. I have no problem with that. But I'll tell you one thing. I want to speak with the doctor directly to make sure the doctor is going to get the proper information. And preferably, doctors do not do well when they answer it by phone without seeing the patient themselves. That's not the way the practice of medicine is. The way the practice of medicine is a physician comes, examines the patient, takes a history and physical, and then renders an opinion. An opinion rendered by telephone in a non-emergency situation, when there's an opportunity to actually see the patient, you have to take that opinion with a grain of salt. Because sometimes they'll say, bring the patient to my office and I'll give X. The patient's in a stretcher. Does your office accommodate stretchers? And as far as transportation is concerned, are you willing to allow Medicare to pay for an ambulance to bring the patient to your office because ambulettes do not transport patients on stretchers? So these are the kind of things, and families are often looking for these. They will always, because there's always this possibility that maybe someone will come with a refuah. And I'm not going to take away anybody's hope, but we also have to be realistic. Like the rabbi said, a person is not allowed to pray if there's a situation that, in a situation where it's a tefillat shav. Sometimes the right thing to do is to recognize that there's not much more that can be done to cure the illness and focus on the day-to-day caring of the patient. I had another family one point where there was a son and basically had a little notebook, and that was probably volume 5 of a 5-volume notebook, because this is how he's been taking care of the patient. And he had everything written down. If I wanted to know medical history, I didn't have to look at the chart. All I had to do was say, tell me what happened in October 15th of 2011, and he'd look over there, and he'd be able to tell me exactly what was going on, what medications, all that is. And I would say that's probably a lot of reason why the patient was actually still alive with this illness so long afterwards. But when it came time, when the patient, in my estimation, was getting very close to death, what I mean by that is a day or 2 or 3, and I was meeting with the family, and he's, of course, taking out that book and taking his pen, I said, can I see that book for 1 second, please? And I took the book, I closed it, and I put it in my pocket. I said, your focus now is not on the book. Your focus now is on being there for your loved one. And he started to cry, because that's exactly what he needed to hear. A couple of weeks ago, I had another family. The family was from out of town. There was one of the children was out of town and basically she was so concerned because she left her husband. Her husband's got to take care of 4 or 5 kids. I mean, God forbid a man should feel what it's like to be a woman for a couple of days. You know what I mean? And the whole house is going to fall apart because nobody does it better, right? So she's telling me how she wants to know if she should go home and, and then come, for the last couple, like I have a Ouija board or a crystal ball that's going to tell me precisely minute and time so she can squeeze in at the last minute. I'm being facetious. That's not how it was. So the first thing I said to her is, I want to call your husband. So, okay, I got him on the phone. I said, let me ask you a question. Do you think you could survive for the next couple of days without your wife? Because if he says she has to come home, The rabbis can say what the halakha is in that situation, but maybe she might have to go home. I said, do you require your wife to go home? What Jewish man's going to say that? I don't know, and be able to not sleep on the couch for a couple of weeks? I don't know. Do you require your wife to go home? She says, no, we're okay. We're fine. It's all right. We'll handle the situation. So then I said, thank you very much. I put her on the phone. He told her the same thing. And I said, okay, now, we're going to stop going to our area of comfort. The mitzvah of kibud av va'em, I think, is probably one of the most difficult mitzvot to do. And there's many reasons for that. And one of the reasons for that is you have to be there. You have to be there, especially in this time. Because look at what Yaakov Avinu did. He'esfu, gather to me and I will tell you what's going to happen at the end of days. Right? Which means this is an idea that before a person leaves the world, what do they want to do? They want to be able to see their family all together. And that hints at something else that Rabbi Glatt said so wonderfully. If there's machloket in the family, for whatever reason, especially about the illness, is that really what the loved one that you're advocating for is looking for? So that in Shamayim during the Shiva, they see two people sitting in the different Shiva house because they didn't trust each other's posek? I don't think in the Olam HaEmet that works so well. So it's so important to maintain the peace and the tranquility. And I will say, and this will conclude, that there is no reason, once again, that patients should suffer at the end of life. And that is not by euthanasia and making death happen sooner. That is by giving them the appropriate medication, the appropriate treatments, so that they can be comfortable, and you perhaps often in those situations extend their life and do exactly what the Torah is looking for us to do. Have a good day.